This lecture is for the undergraduate dental students given by Dr.Nadia, a specialist and a lecturer orthodontist. The title of this lecture is the Class II Malocclusion. The main objectives of this lecture is to define the meaning of the Class II malocclusion, then to know the main etiological factors that leads to that malocclusion. Then we are going to know the clinical features and how we are going to manage the Class II malocclusion. So the Class II malocclusion definition is that type of malocclusion in which the buccal group of the mandibular first permanent molar occlude distal or posterior to the mesiobuccal cusp of the maxillary first permanent molar. Dr. Angle has further subdivided the Class II malocclusion based on the incisor relationship into two types. We have the Class II Division 1, in which the molar relationship is Class II, but we have a proclination of the upper anteriors. And we have the Class II Division 2 malocclusion, in which the molar relationship is Class II, but we have a retroclination of the upper central incisors, and they are usually also overlapped by the lateral incisors. So what are the etiology? Basically, we have three important factors that leads to the development of this malocclusion. These factors sometimes are happening all together, or sometimes one of them is overriding the other factor. Those factors are the skeletal, the soft tissue, the dental, and the habits. Let us start by the skeletal factor. When we say we have a skeletal Class II relationship, it indicates that we have an anterior-posterior discrepancies or disproportion in size or position of the jaws relative to each other, rather than a simple malposition of the teeth relative to the jaws. For a Class II Division 1 relationship, it is usually associated with a skeletal Class II pattern, either due to mandibular deficiency, so the mandible will be too small or protruded relative to the maxilla, or sometimes it may happen due to maxillary excess, so the maxilla is too large or protruded relative to the mandible, and sometimes we have both of them. Anyway, if we have a proclination of the upper incisors or retroclination of the lower incisors by habit or by a soft tissue, we may have an increased overjet over a Class I or even a mild Class III skeletal pattern, but it is less common. For the Class II Division 2 malocclusion, it is commonly associated with a milder degree of a Class II skeletal pattern and a reduced vertical dimension with a high lower labial lip line. So the increased or the Class II relationship, skeletal relationship, and the reduced vertical dimension result in the absence of the occlusal stop to the lower incisors. So they are going to continue to erupt, leading to an increase in the overbite that is usually associated with the Class II Division 2 malocclusion. The second factor, which is the soft tissue factor here, the lips relationship, the influence of the lips on the Class II is almost entirely determined by the basal bone relationship to which they are attached, both anterior-posteriorly and vertically. But in general, in Class II malocclusion, especially in Class II Division 1 relationship, the lower lip will tend to be further backward than the upper lip. So, this will not only increase the difficulty in bringing the lips together to have the lip competency, but it will also modify the eruption pathway of the upper centrals. So it will increase or decrease the severity of the skeletal relationship. For example, if the skeletal discrepancy is mild to moderate, like if the patient have a mild to moderate skeletal relationship, the lower lip will function partly or completely behind the upper central incisors. So they are going to procline them, they are going to push them forward, and the increased overjet will be both due to the skeletal Class II relationship and also due to the proclination of the upper incisors by the soft tissue factor. But what if the patient have a more severe skeletal relationship? In the severe skeletal pattern, the lower lip will be behind the upper incisors, so they will not have an effect on them and they will not procline the upper incisors. And we can say that the increased overjet is just because of the skeletal Class II pattern, jaw relationship. For the Class II Division 2 skeletal relationship, As we said, the skeletal relationship is milder and the patient will have a decreased lower anterior facial height, so the lower lip will be higher than it is usual. It will cover more than the one-third, the common normal one-third coverage of the upper incisors. So they are going to have more effect on the upper centrals and they are going to retrocline them. In some cases, when we have a shorter clinical crown of the lateral incisor, it will escape the effect of the lower lip and they will either have a normal inclination or sometimes even become proclined due to the effect of the lower lip. For the dental factors, the class 2 division 1 may occur in the presence of spacing or crowding. When the arches are crowded and we have a lack of space that is enough to align the teeth properly, usually those teeth will be procline and so they are going to increase the amount of overjet. Conversely, if the crowding is happening in the lower labial segment and they are procline, they are going to decrease the amount of increased overjet. So they are going to decrease the severity of the class 2 relationship. Crowding usually is commonly seen in the class 2 division 2 malocclusion due to the retroclination of the upper central incisors, so the teeth will be aligned on a smaller arch circumference or a smaller arch diameter. As we said before, the absence of the occlusal stops will result in the increase or over-eruption of the lower incisors, so in the majority of the cases, the class 2 malocclusion is usually associated with increased overbite. The fourth factor is the habit. The presence of a habit such as the digit sucking will act like an orthodontic force upon the teeth, especially if it was practiced several hours per day. The severity of any habit produced will depend on the duration, intensity, and also the frequency of the habit. But among all of these factors, the most important one is the duration, the time spent during practicing such habit. The effect of the habit for any child will depend also on the skeletal relationship. The child may have a pre-existing class 2 relationship, so it will increase the severity of the class 2, or sometimes it will give us a class 2 incisor relationship on a class 1 or a class 3 skeletal relationship. In most of the cases, the effect of any habit will be asymmetric, especially if a single finger is usual. In this picture, we see that this child is sucking his thumb, so this thumb will exert forces on the teeth and will cause proclination of the upper anteriors and retroclination of the lower anteriors, so the child will have increased overjet. Also, he may have an anterior open bite because the presence of thumb will prevent the normal eruption of the upper and the lower anteriors. Also, the separation of the jaws will lead to the over eruption of the posterior teeth. Also, the presence of the thumb sucking habit will increase the forces of the cheeks on the maxilla, so it will become more than the force of the tongue, and we will have a constriction of the maxilla. We have to keep in mind that as the child is practicing the habit in the primary dentition, most of those features will disappear once he stops practicing this habit. But those effects will be more permanent if the child continues to do this habit during the permanent dentition. So our orthodontic intervention for the child who practices thumb sucking habit will be before the eruption, should be done before the eruption of the permanent teeth. Clinical features of the class 2 division 1, we have extraoral and intraoral feature. For the extraoral feature, the frontal view, depending on the severity of the skeletal class 2 relationship and depending whether it is associated with vertical discrepancies or not, the frontal view is usually oval, mesocephalic in the mild to moderate cases, or dolichocephalic, which means that the patient have a long and narrow face. In the profile, also, as we said, it depends on the severity of the skeletal pattern, but in most of the cases we will have a convex profile. We will have an incompetent and stretched upper lip due to the proclination of the upper incisors. The lower lip is usually everted and placed behind the upper incisors, so it will exhibit a deep mentolabial sulcus. The intraoral feature, the first one is the class 2 molar relationship. The upper incisors are brook-lined, increasing the overjet. We may have a deep bite, and sometimes it may be traumatic in nature, which means that the lower incisors is causing trauma to the upper palatal rugy area. We have an exaggerated curve of SP. The maxilla is usually narrow, V-shaped, and the palatal vault is deep, or sometimes the Class II Division 1 may be associated with other features like anterior open bite or posterior cross bite, especially if it was associated with a habit, as we said before. For the clinical features of the Class II Division 2, it is usually different from the Class II Division 1, both extraorally and intraorally. How is that? In the frontal view, the patient will have a squarish face, or what is called a brachycephalic face, which means he has a short and broad face. As we said before, that the Class II Division 2 is associated with decreased lower anterior facial height. Unlike the Class II Division 1, the patient frontal view is dolichocephalic or mesocephalic. In the profile view, as we said before, that the Class II Division 2 is usually associated with milder skeletal Class II pattern, so the profile is usually straight or mild convex. The upper lip is short and high relative to the upper incisors. The lower lip is high, so it will cause a retroclination of the upper incisors, and in most of the cases we have an adequate lip seal. Unlike the Class II Division 1, in which we said that the patient may have a competent, but most of the cases we may have lip incompetency, depending on the severity of the skeletal Class II relationship. Orally, we have a Class II molar relationship. The upper incisors will be retroclined, and this will result in decreasing the overjet, but we will have an increased overbite due to the lack of the occlusal stop, so we will have an over-eruption of the lower incisors, and because we have a deep overbite, it depends on the severity. We may have traumatic overbite, which means that the lower incisor will cause a trauma to the palatal rugy area, and if it was bitraumatic, the upper incisors will cause trauma to the lower labial mucosa. We have also an exaggerated curve of SP. The upper arch is U-shaped and the palatal vault is usually deep. Now let us consider the management of the Class II malocclusion. The management of the Class II malocclusion usually depends on important four criteria. Our treatment plan will greatly change depending on the age of the patient. Is the patient growing or not? If the patient was still growing, we may consider redirecting his growth pattern towards the correct one. Like, for instance, if the patient has a protruded maxilla and excess in the maxillary growth, we may consider using a headgear. Or if the patient has a deficiency in the mandible, a small mandible or a protruded mandible, we may increase his growth by using a functional appliances. The second factor is the severity of the malocclusion. Is it mild, moderate, or severe? Can we solve it by using the orthodontic treatment, or we may need orthodontic surgery, for example? The third one is that what is the etiology of this malocclusion? Because it is very important when we consider treating any malocclusion is to solve the main etiological factors that lead to the development of this malocclusion. And this, of course, will depend upon correct examination and correct diagnosis, from examining the diagnostic records, from the clinical and from functional examination, by using a cephalometric analysis, and so on. And lastly, the patient profile will also can change our treatment plan. If the patient profile is convex, we may consider retroclining the upper incisors to get the straight profile. But what if the patient have already a straight profile? We may not change that profile. Treatment objectives of the Class II malocclusion is four. The first one is the relief of the crowding or any local irregularities. The second one is the reduction of the incisal overbite, because if the incisal overbite is excessive, it is not possible to reduce the overjet completely. We will not have a freedom to move the upper and lower incisors without reducing the overbite. So the reduction of the incisal overbite is a frequent part of the angles class 2 division 1 malocclusion treatment, and usually it is carried out as one of the first stages. After completing the incisal overbite, we may reduce the incisal overjet by retroclining the upper anteriors or proclining the lower, depending on the case. And lastly, the correction of the buccal segment relationship by moving the molars, the upper molars distally and the lower molars medially. We have three treatment modalities depending on the above mentioned factors. The first one is the growth modification, the second one is the camouflage treatment, and the third one is the orthodontic surgery. Let us start by the growth modification. So if the patient is still growing and he has got a mild to moderate skeletal class 2 relationship, we may consider using any one of the growth modifying appliances depending on the etiology of the malocclusion. If the patient has a maxillary prognathism and a normal mandible, we should consider using the headgear to restrain the maxillary growth, both horizontally and vertically depending on the force applied to the maxilla. And if the patient has a normal maxillary growth but a deficiency in the mandible, so he will have a retruded mandible or a small mandible, we should consider using myofunctional appliances to encourage and redirect the growth of the mandible in a more anterior direction. And we have different types of myofunctional appliances like the monoblock, like the Herbist, like the Tuniblock, and so forth. And if the patient have a combination of maxillary prognathism and mandibular retrognatism, we may consider using a combination of the headgear and myofunctional appliances. But all these appliances will depend mainly on the patient compliance. So we may consider encouraging the patient to wear their appliances to have a successful treatment plan and a successful result. We can see in this video that this patient has a class 2 division 1 malocclusion due to retruded mandible, so we consider using the myofunctional appliances. In this video it is the bionator. The bionator will encourage the forward growth or redirect the forward growth of the mandible, so it will help us to correct the skeletal class 2 pattern, and we will have a class 1 molar relationship at the end. Usually we use the myofunctional appliances during the late mixed dentition period. This is the monoblock appliance. Now the second treatment option is the camouflage treatment. The camouflage treatment is indicated for non-growing patients with mild to moderate class 2 relationship or in cases with a class 2 malocclusion but it is of dental origin. The main goal of the dental camouflage is to move the teeth in such a way to hide the unacceptable skeletal relationship. So, in the most of the cases, we are going to extract the primo-first permanent molars and then we are going to retract the upper anteriors to have a more acceptable occlusion and a more aesthetic facial appearance. And this can be done by using a fixed appliance or a removable appliance. But in most of the cases, we prefer to use the fixed appliance to achieve the bodily retraction of the upper incisors after extracting the premolars. So at the end of the treatment, the patient will have an incisor class 1, but the molar relationship will still be class 2 molar relationship. Sometimes, if a child has a moderate to severe class 2 skeletal pattern, we may consider use a combination of the two approaches, of the growth modifying approaches and the camouflage treatment. So we will start the treatment at the late mixed dentition, and the patient will wear the functional appliance until the jaw relationship is corrected. Then he is going to be shifted to the camouflage treatment, and we will extract the upper premolars and retract the interiors to have the perfect results. On this video, we can see that the patient has a class 2 division 1 malocclusion. Let us see. The patient has a class 2 division 1 malocclusion. We extract the upper first permanent molar and then we retract the interiors, and at the end of the treatment we see that the patient is still having a class 2 molar relationship but a class 1 incisor relationship. After we discussed the growth modification and the camouflage treatment, let us discuss the orthodontic surgery choice. This is when we have a severe anterior-posterior discrepancies, a severe skeletal class 2 pattern, associated with a severe vertical discrepancies like a marked increase in the lower facial height or significant reduction in the lower facial height. The orthodontic treatment alone will not be sufficient. So we will need a combination of orthodontics and surgery to produce the aesthetic and the stable correction of the malocclusion. And we have different types of surgeries. This is not the scope of this lecture. Like for instance, if the patient has a protruded maxilla, we may consider using the Fort 1 osteotomy to retract it, or if the patient have a protruded mandible, we may consider using the bilateral sagittal split osteotomy to protrude the mandible in an anterior direction. In this video, we are going to see the most commonly used orthodontic procedure to correct the severe class 2 malocclusion. In the first case, we see that the patient has a class 2 division 1 due to protruded maxilla, and we have a vertical maxillary excess. So we are going to treat it by using the Fort 1 osteotomy to do the retraction of the maxilla and also the maxillary impaction. In the second case, the patient has a class 2 division 1 malocclusion, but it is due to a protruded mandible. So we'll start by using the orthodontic treatment to align the teeth, and then it is treated by using the bilateral sagittal split osteotomy to protrude the mandible and have a more normal jaw relationship, class 1 jaw relationship. Treatment of the class 2 division 2 cases are not so different from the class 2 division 1. In general, the first thing to do is that to procline the retroclined incisors to be aligned in a proper labiolingual direction, or in other words, converting the case into a class 2 division 1 malocclusion. Then the treatment sequence in most of the cases are the same. This is the end of the lecture. If you have any question, please do not hesitate to contact me, and I will be happy to answer you. Thank you.